Welcome back to the deep dive. Today, we're all about precision.
Hmm.
If you're a plastic surgery resident, a trainee, or, you're staring down the barrel of the FRCS or board exams, this is for you.
This is a big one.
We're taking the huge, complex world of oculoplastic surgery and eyelid reconstruction and boiling it down to the absolute essentials.
It's a massive topic,
Mm-hmm.
but it's also, I think, one of the most rewarding. This pure structure, pure function.
Yeah.
Oculoplastics is really where that high-yield anatomy meets the reconstructive ladder.
And in a very unforgiving space, you really can't hide a bad result on an eyelid.
You can't.
So because this is so dense, we're going to be pretty ruthless today. We're stripping away the fluff, building the anatomy from the bone up, looking at the plumbing of the lacrimal system.
And the big part.
And then the part everyone stresses about, walking through the reconstructive algorithms for the upper and lower lids.
We'll cover the golden rules.
Mm-hmm.
The things you just can't break if you want to pass your exams, and, more importantly, protect your patient's eye.
Exactly. Okay, before we make that first incision, quick housekeeping. If you want to catch these revision deep dives as soon as they drop, please hit follow right now on your player.
And if this stuff is actually helping you, survive your rotation, a rating would be great. It helps other trainees find this material.
For sure. And leave a comment. If there's a topic keeping you up at night, let us know. We build this schedule around what you need.
Yeah, we do.
Last thing, we're sticking to the core curriculum today. But if you want the really advanced stuff, the journal club breakdowns or the clinical cases where we put you under pressure, you need that premium subscription.
That's where we really get into it. But for today, the mission is clear.
Anatomy, lacrimal system, and reconstruction. And just a quick disclaimer, this is all factual review from the standard texts. No personal anecdotes, no in-my-hand surgery today.
Just the science you need for the exam. Let's get to it.
All right, you cannot reconstruct an eyelid if you don't understand the layers. And the most fundamental concept, I think, is the lamellae. It sounds simple, but people get tripped up on where that dividing line actually is.
It's a surgical distinction, really.
Yeah.
We sort of arbitrarily divide the eyelid into two sheets. You have the anterior lamella, which is your cover. That's the skin, and the orbicularis oculi muscle.
Okay.
And then the posterior lamella is your lining and structure, so the tarsal plate and the conjunctiva.
And the meeting point of those two.
The gray line. If you look at an eyelid margin, even with the naked eye, you can see that subtle gray line running right along the middle. That's your surgical demilitarized zone.
So if you split the lid there, you're separating muscle from tarsus.
Exactly.
Now, in some of the newer literature, you hear this term middle lamella. Is that a real thing or is it more of a concept?
It's real, but it's location dependent. The middle lamella refers to the tissue sitting between the anterior and posterior layers, so the orbital septum and the preaponeurotic fat.
Ah, but there's a trap there.
There's the exam trap. There is no middle lamella in the region of the tarsal plates.
Right, because at the tarsal plate, skin and muscle are almost directly on the tarsus.
Exactly right. The middle lamella exists higher up, but it disappears as you get closer to the margin.
Okay, let's drill down into that structural support, the tarsal plates.
They're the skeleton of the lid, not cartilage, though they feel like it. They're dense fibroelastic sheets, and crucially, they house the meibomian glands.
Which gives us our landmarks.
Right. The openings of those glands mark the mucocutaneous junction, and that is posterior to the gray line. So anterior to posterior, it's lashes, gray line, meibomian orifices, then conjunctiva.
That's a perfect visualization. Let's move back a layer. The orbital septum, the gatekeeper.
It is. It separates the eyelid from the orbit proper. It starts at the arcus marginalis, just a thickening of periosteum at the orbital rim, and then it heads down to insert on the tarsus.
And that insertion point varies a bit, doesn't it?
It does, and that variation explains so much about eyelid aesthetics. In many Caucasian eyelids, the septum fuses with the levator aponeurosis before it even reaches the tarsus.
But in some Asian eyelids, it's different.
Exactly. The septum inserts lower down, directly onto the anterior face of the tarsus, and that allows the preaponeurotic fat to slide down and sit anterior to the tarsal plate, giving a fuller appearance.
We'll come back to that. Let's stick to the muscles, orbicularis oculi.
The sphincter of the eye,
Yeah.
innervated by the facial nerve, your temporal and zygomatic branches.
And functionally, you split it.
You have to. The orbital part, that outer ring, is for forced closure, scrunching your eye shut.
And the inner part.
The palpebral part, that's for the involuntary blink. And we even subdivide that into pretarsal over the tarsus and preceptal over the septum.
The bony attachments here are so high yield for trauma questions. The medial side.
The medial canthal tendon, it's complex. It splits around the lacrimal sac. You have a superficial limb anterior to the crest and a deep limb that goes posterior to the lacrimal sac
And why does that matter so much?
because it creates the lacrimal pump. Every time you blink, the orbicularis contracts and squeezes that sac, creating negative pressure to suck tears down. Break the MCT, you break the pump.
Got it. Okay, let's switch to the opener. Levator palpebrae superioris.
Originates way back at the orbital apex, runs forward, and then it hits a critical structure.
Whitnall's ligament.
The pulley. Exactly. Whitnall's acts as a fulcrum. It converts the horizontal pull of the muscle into the vertical lift of the eyelid. After that ligament, it becomes the aponeurosis.
And that aponeurosis attaches where?
Primarily into the anterior surface of the tarsal plate. But it also sends these little fibrous bits forward through the orbicularis to attach to the skin. And that is what creates the upper eyelid crease.
Before we leave muscles, we have to mention the little helper, Muller's muscle.
The superior tarsal muscle. It's smooth muscle, sympathetically innervated. It's not doing the heavy lifting, only about 2 to 3 millimeters of elevation.
But if you lose that sympathetic drive, like in Horner syndrome...
You lose that 2 millimeters and you get that classic mild tortosis.
Let's talk fat pads. Blepharoplasty is everywhere, and you have to know which pad is which.
Upper lid, 2 pads, medial and central.
So why no lateral pad in the upper lid?
Because the lacrimal gland lives there. That is the classic board question trap. If you're digging around for fat laterally in the upper lid and you excise something, you've probably just taken out the patient's lacrimal gland.
Note taken. And the lower lid.
3 pads, medial, central, and lateral. And the inferior oblique muscle separates the medial and central pads.
Okay, last anatomy point, Ru and SO, just quickly.
Yeah. Retroorbicularis oculi, that's our OOF, in the eyebrow upper lid. And suborbicularis oculi fat, SOFF, in the cheek lower lid junction. They're both perceptual fat, so technically outside the orbit.
Perfect. Let's do rapid fire in the lacrimal system. The plumbing.
It's a 3-layer tear film. Inner layer is mucin from goblet cells, makes tears stick.
Okay.
Middle layer is aqueous from the accessory lacrimal glands. Outer layer is the oily lipid layer from the meibomian glands, which prevents evaporation.
And the drainage. Give me the numbers.
Tears enter the puncta. Then they travel through the canaliculi. And you have to memorize these dimensions.
2 vertical, 8 horizontal.
2 millimeters vertical, a 90-degree turn, then 8 millimeters horizontal. They join at the common quintuliculus, dump into the lacrimal sac, and drain down the nasolacrimal duct into the inferior meatus of the nose.
Excellent. That's the foundation. Now, let's get to the reconstruction.
This is where the art meets the science.
When we're faced with an eyelid defect, what are the absolute non-negotiable goals?
Number 1, protection of the globe. A pretty eyelid that leaves the cornea exposed is a total failure. You need stable skin, you need structural support, and you need a mucous membrane lining.
And there are golden rules here.
The most important rule in all of oculoplastics: never put skin on the conjunctiva.
Why not? What happens?
Skin has keratin. It has fine hairs. If that rubs against the cornea thousands of times a day, it's like sandpaper. You'll get abrasions, ulcers, and potentially blindness. It must be a mucous membrane lining.
Got it. And rule number 2.
Reconstruct the lamellae separately. If you have a full thickness defect, you need a posterior reconstruction and an anterior one. Don't just mush it all together.
Okay, let's walk through the algorithms. Exams love this. They give you a defect size, you give the solution. Let's start with the lower eyelid.
Go for it.
Scenario A, small defect. Less than, say, 1/3 of the horizontal width.
Direct closure. You don't need fancy flaps. Excise it in a pentagon shape to get clean vertical edges through the tarsus, align the gray line perfectly, and close in layers.
Any trick to that excision?
A pentagon is better than a simple V to prevent notching. And if you have a dog ear of skin at the bottom, angle it laterally. That way the scar pulls the lid up and out, not down into an ectropion.
Smart. Okay, scenario B, medium defect. Between 1/3 and 1/2. Direct closure is going to be too tight.
Now you need to mobilize the lid. First step is lateral cantholysis.
Explain that.
You go to lateral campus, make a small cut of canthotomy, then you find the inferior crus of the lateral canthal tendon, and you just snip it. You're disconnecting the lower lid from the orbital rim.
And how much length does that buy you?
About 5 to 10 millimeters. Usually enough for a medium defect.
And if that's still not quite enough?
And you go to a tensile flap. It's a semicircular rotation flap from the lateral canthus, arsing up and out. You rotate that skin and muscle in to fill the gap.
Okay. Scenario C. The big ones. A defect greater than half the lower lid. Cantholysis isn't going to cut it.
Now you're in tissue sharing territory. You have to borrow from the upper lid to fix the lower lid. The workhorse here is the Hughes flap.
A tarsoconjunctival flap. Walk us through it.
Okay, so you've got this big hole in the lower lid, no posterior lamella. You look at the upper lid, you invert it, flip it inside out. You make an incision through the conjunctiva and tarsus on the inside of that upper lid.
But you have to leave the margin intact, right? That's the key.
Absolutely critical point. You have to leave at least 4 millimeters of tarsus at the upper lid margin, or you destroy its stability.
Mm.
So you take the tarsus and conjunctiva from above that 4 millimeter mark, dissect it free, and pull it down into the lower lid defect.
So you were literally sewing the upper lid to the lower lid.
Yes. You're creating a wall of tarsus and conjunctiva across the eye. That's your new posterior lamella.
And what about the front? The skin?
The Hughes flap is just the lining and support. You've got a raw surface facing out. You have to cover that with either a skin graft or a local skin flap.
And the patient's eye is sewn shut.
It is. It's a two-stage procedure. They stay like that for about 3 weeks, then you bring them back and divide the flap.
So Hughes is upper to lower. Got it. Let's flip it. Upper eyelid reconstruction.
Higher stakes here.
Much higher stakes. You need movement. Small defects, less than a third, are still direct closure. Medium, up to half, you can do a lateral cantholysis or a tensile flap.
But for the massive defects, greater than 50% of the upper lid, we need the reverse of the Hughes.
Like Cutler beard flap.
The bucket handle. Describe this one, because the geometry is tricky.
Okay, you're borrowing from the lower lid to fix the upper. But you can't just drag the whole lower lid up, you'd blind the patient.
So you have to preserve the lower lid margin. Exactly. You create a full thickness flap in the lower lid skin, muscle, everything. But you leave a bridge of intact margin, about 4 to 5 millimeters thick.
Ah, so the marginal artery is safe in that bridge.
That's the key. You make your incision below the tarsal plate of the lower lid, you raise that flap, and you pass it under the bridge like a belt through a loop. You pull it up into the upper lid defect and suture it.
Great visual. The lower lid margin stays put, and the tissue slides underneath it to get to the top.
Precisely. Again, the eye is occluded, this time for about 6 weeks. Then you divide it.
Okay, so to recap the big ones. Hughes for lower lid defects, you bring tarsus down from the upper. Cutler beard for upper lid defects, you bring full thickness tissue up from the lower, under a bridge.
You've got him.
Let's wrap up with a quick inventory of spare parts. If I need a graft, where am I going?
For anterior lamella, skin, the best match is the other upper eyelid. Second best is retroauricular, behind the ear.
And for posterior lamella, for structure and lining?
You need something stiff with a mucosal lining. So a hard palate graft from the roof of the mouth is classic, or auricular cartilage from the ear bowl. Nasal septal chondromucosal grafts work well too.
It's pretty amazing when you think about it. We're moving tissue from the mouth, the ear, sewing eyelids shut. How does any of this survive?
And that's really the final provocative thought. The reason we can do all this in the face is the blood supply. It's just incredible. The face is a meeting point of two massive vascular systems.
The carotids.
Right. You have the internal carotid system coming up through the ophthalmic artery, and you have the external carotid coming up through the facial and temporal arteries. They all collide and connect right there around the eye.
So when you rotate a tensile flap or pull up a Cutler beard, you're tapping into this supercharged vascular network.
Exactly. It's why facial flaps are so forgiving compared to, say, a leg flap. The biology just wants to heal. Our job is to put the tissues in the right place so they heal in a shape that protects the eye.
Anatomy, physiology, and geometry. The holy trinity of oculoplastics.
Couldn't have said it better myself.
We have covered so much ground. From the lamellae all the way to the bucket handle flap. If this was useful for you, please just take 2 seconds to rate the show. It's the best way to help us grow.
And don't forget to subscribe to Premium. In the next clinical cases, we're going to give you a patient with a BCC eroding the medial campus and the lacrimal system, and you're going to have to choose the reconstruction.
You definitely don't want to miss that. Until next time.
See you in the next deep dive.